Hello, everyone. Thank you and welcome to our discussion today on the South Sudanese Women Intellectuals Forum. My name is Dr. Anne Lomole, and I will be your moderator today. I'm a pediatrician and an infectious disease consultant. And today we'll be talking on a very, very important topic, adolescent access to family planning. Adolescents are considered a special group that have largely been marginalized, despite the fact that they form 16% of the world's population. When it comes to healthcare and access to health services, they're largely dependent on caregivers and adults. Provision of sexual and reproductive health services to this population is difficult because we have to think of issues like age of consent, confidentiality, parental permission. Family planning access to adolescents is therefore influenced by many factors that are beyond their individual control. This should, however, not be the case as more and more adolescents are having early sexual debut with little or no information on how to protect themselves from sexually transmitted diseases and little or no access to family planning or information on family planning. So today we will focus on adolescent access to family planning. We will discuss the barriers, the challenges faced by adolescents in accessing and utilizing family planning, the ethical considerations, and some of the recommendations that our panel of experts have. We are currently streaming live on Facebook and on YouTube. Please feel free to post any questions on our Facebook wall. And I would like to thank our audience for joining us and for their support. I would also like to thank our panel of experts for taking time out of their busy schedules to join us for this important discussion. I'd also like to thank our donors and those who have supported and continue to support the South Sudanese Women Intellectuals Forum. And I'd like to thank the South Sudanese women and the South Sudanese people in general. So I'll just go straight ahead and start with the introductions. We'll start with Dr. Idioro. Joseph is a practicing obstetrician and gynecologist at the Mater Hospital in Nairobi. She did a Bachelor's of Medicine and Surgery in the University of Juba and her Master of Medicine in Obstetrics and Gynecology in the University of Nairobi. She is a fellow of the Eastern, Central, and Southern African Obstetrician and Gynecologist Society, and she recently completed her fellowship in gynecological oncology and is the first gynecological oncologist in South Sudan. Dr. Idioro, welcome to our panel today. Next, I'd like thank you for coming, Dr. Idioro, and for taking your time to join us today. Next, I would like to introduce Dr. Roberts, who has over 9 years experience in the developmental and humanitarian sector, primarily with a focus on reproductive, maternal, neonatal, and adolescent child health. Currently working with the UNFPA as a medical doctor with a master's degree in health policy planning and financing. He brings both technical expertise and strategic insight to his work. From South Sudan to the UK to Iraq and now back to South Sudan, he has had the privilege of serving with the United Nations and several international NGOs in this and other capacities, with a shared goal of building resilient and equitable health systems to strengthen maternal and child health services. Thank you, Dr. Roberts, for joining us today, and welcome to the South Sudanese Women Intellectuals Forum.
Thank you for having me.
Thank you. Next, I'd like to introduce Mr. Busiri Julius, who is a South Sudanese public health specialist with a strong interest in policy and programming for sexual and reproductive health and rights. He has extensive experience in academia, research, and humanitarian response. He holds a bachelor's in community health and a Master of Science in public health and in medical sciences from the Karolinska Institute in Sweden. He prides himself as a male feminist and promoter of girl and women empowerment in both his professional and private life. He's also a creative artist, a painter, and a comic illustrator whose main focus is social equity and health. He's currently a program specialist at the UNFPA in South Sudan. Thank you, Mr. Busiri Julius, for joining us today. Next, I'd like to introduce Ms. Anna Alex, who at some point will also double as a moderator. Anna Modong is a sexual reproductive health practitioner with over 6 years of experience across South Sudan and Uganda. Currently, she works with Amref Health, South Sudan, under a UNFPA funded project. She did her Bachelor's of Nursing Science in Uganda Christian University, and she's currently pursuing a master's degree in public health, population, and reproductive health from the Uganda Matters University. Anna is driven by her passion for sexual reproductive health rights, and particularly issues around adolescents, family planning, and safe motherhood. Her desire to see adolescents' inclusion into issues of sexual reproductive health and the need to allow women and adolescents to have control over their reproductive information and health information and decisions is of high priority to her. Her concept and perception around doing this is to continue to appreciate the different cultures, religion, and social norms within the context of South Sudan, but on the other hand, emphasize the need to respect the rights of this marginalized group of people. Thank you, Anna, for joining us for this discussion today. So at some point, Anna will take over from me in terms of the moderation. Ms. Modong is unable to join us due to other reasons, and we hope that she'll be able to join us maybe for the next discussion. So we'll go straight ahead and start the discussion today. We'll start with Anna Alex. Anna, could you please tell us the work you do and how it relates to sexual and reproductive health? Maybe just a brief overview.
Thank you so much for having me here. Good afternoon, good morning, and good evening, everyone. Just to be precise, the work I do is all about sexual reproductive health. And I work a lot on issues to do with adolescents, issues to do with youth, issues to do around safe motherhood, but basically from the community perspective. So I interact a lot with youth to know their sexual need, at the same time to look at how we can empower them to have control over themselves, to make decisions for themselves. At the same time, I work with adolescents. We have programs around adolescent sexual reproductive health, whereby we target adolescents in school and out of school, ensuring that they get access to information, comprehensive sexuality information. We also capacity build teachers to ensure that comprehensive sexuality education in school is part of the teaching on daily basis. And also we do a lot around family planning, service provision, information through awareness creation, both in radio station. We have different private sector we partner with to ensure that we provide them with commodities that aids expansion of information, at the same time services, as far as family planning is concerned. So that is basically what I do around adolescents and family planning.
Thank you so
I
much,
think
Anna, for that.
thank you.
Thank you for that. I think before we go to the rest, I'd like you to just set the base for us and explain to us what is meant by an adolescent and what is family planning. If you could just give us the definition so that the people who are listening to us can understand what we're talking about.
Okay, thank you. I'm sure a lot of people might have heard about adolescents, and you could be asking yourself what an adolescent is. Adolescent is a person. I would say that. Yes, all of us have gone through that stage. So adolescent is a stage whereby it's a stage from 10 to 19 years. That is according to WHO. And in that stage, it's basically a lot is happening around with these people or with this person that is an adolescent, physical, emotional, and hormonal as well. So there is a lot that is happening. So when someone is between the age of of 10 to 19 years. We term them as adolescent. So it's a bridge, it's a bridge between childhood and adulthood. And this is a period that really a lot of important people make a lot of important choices and decisions about themselves, and that is why it makes it a very complex stage in life that needs a lot of interventions, a lot of guidance to ensure that these people cross through that to the adulthood in a safe manner, I would say that. And family planning, I would mention it's a practice whereby it's a practice that we choose or decision that we take on how many children, spacing, and how many children we need to have. So if someone is talking about family planning, it's all about proper spacing. And why we say proper spacing is important is because it has a lot of health impact to the women themselves and to their unborn children. So we need a spacing between one pregnancy to another to allow our bodies to heal, to allow our bodies to go back to their previous post-pregnancy or pre-pregnancy period. That's why we talk about family planning. It's not about stopping us from getting pregnant. It's not about reducing our population, but it's just about having the right choice at the right time. Thank you. Back to you, Anna.
Thank you so much for that, Anna, especially the last part where you say it's about the right time and the right choice. I think it's important to remember that. I'd like to now go to Dr. Roberts. Dr. Roberts, tell us a little bit about the work you do and how it relates to sexual and reproductive health, and then we can ask you the next question about, in terms of statistics of access and utilization in South Sudan. Do we have any idea how that is in South Sudan for the different ages and genders? So tell us a little bit about the work you do in this.
Yeah, thank you, Dr. Anna, for inviting me first of all to this talk show. Good evening to everyone, the South Sudan Women Intellectual Forum, and to those who are tuning in online. I am Jugo Roberts, a medical doctor and a public health specialist. I have the privilege to be working with the UNFPA in South Sudan as an SRH program consultant. So my work revolves around enhancing awareness, education, health access, areas of sexual reproductive health and area. Some of which have already been mentioned by Anne already. It's about ensuring that every individual, regardless of age, gender, has the knowledge, means to make informed choices about their reproductive health. About the statistics that you mentioned there, in the context of South Sudan, the intricacies of access and utilization of sexual reproductive health are quite vast, and they fluctuate depending on age and gender. Just to dive deeper into the figures and the underlying dynamics, there is, of course, a discernible trend that while overall awareness regarding family planning and services has experienced an upswing, adolescents, especially our young girls, confront a lot of challenges in accessing all the services in the country. So the data paints a picture where girls have notably very low utilization rates. One might ask why this is so. So the reasons are really so many, ranging from social-cultural barriers that play a significant role to the lack of comprehensive sexual education, which is another contributing factor. I wouldn't say lack, probably operationalization of comprehensive sexual education is a little low. And also, let's not forget the issues of earlier marriages, which can disrupt access to formal educational systems, and consequently awareness about sexual reproductive health. This evident disparity actually between the boys and the girls comes from deeply entrenched societal norms and stigma surrounding female sexuality, especially in this country. Now, addressing this is really challenging. This kind of conversation is good that we're having with you, and this imbalance addressing this shouldn't be just quick fix. I think, in my view, starting with this kind of conversation and embark on a journey that is of sustained community awareness, including all these campaigns, advocacy at the top level, grassroots level, including comprehensive sexual education. So this education not only target, in my view, our girls, but also our boys, and it should foster an environment of mutual respect, understanding, and also informal decision making. Thank you, and over back to you.
Dr. Roberts, I wanted to find out if you could expound a little bit about the comprehensive sexual education. What does it entail?
Thank you. The comprehensive sexual education actually gives these youngsters, from the definition that my colleague Anne had already given, these are young people who are transitioning from being children to adult. So this education informs these children, these young, rightful choices. So these comprehension can be embedded, of course, in our educational curricula in schools, and also through us who speak for us and all other forums that reach this, basically to make choices that can enable them to become better as tomorrow. Things when we talk about family planning, so that they are able to prepare their bodies to wait when they are capable of course, having these children. Of course, just to wait until that appropriate time, and they are, of course, responsible adult, probably at our age or a little bit younger, but someone who is responsible and be able to take care of themselves, to make those informed decisions on with their bodies and their futures. So comprehensive sexuality education is sort of huge, it's wide, but of course, essence is to prepare these youngsters to become better adults in the next life. Thank you.
Thank you for so much for that, Dr. Roberts, for explaining to us what comprehensive sexual education is, and the fact that it can also be introduced to schools so that it's part of our formal education, and these children are actually advised on making decisions on their sexual and reproductive health based on the information they're provided. I'd like to go to Mr. Busiri Julius. Mr. Julius, could you please just mute yourself for a minute? Mr. Julius, tell us a little bit about the work that you do and how it relates to sexual and reproductive health. And then if you can expound to us what some of the family planning and sexual reproductive health services that should be provided to adolescents, and what are the features of adolescent-friendly family planning and sexual and reproductive health services, and how can these services be made friendly to adolescents? Mr. Julius.
Yeah, thank you so much, Dr. Anna. Yeah, as probably you realize whatever I'm saying will be building on what Roberts has said, because we share a space in the office. But I would want to state that UNFPA, where I work with Roberts, is the United Nations Agency for Sexual and Reproductive Health. So whatever we do is by and large around sexual and reproductive health of both men, women, boys, and girls. But to just go straight to the point, the work I do is mainly around creating an enabling environment by working with the Ministry of Health specifically, but also with other line ministries like the Ministry of Gender, Ministry of Youth and Sports, at least in this country, and the various UNFPA implementing partners to design, implement, and monitor programs and policies that are aimed at ensuring that all South Sudanese, regardless of gender, regardless of age, have equal access to sexual and reproductive health services across the continuum of those services. And that ranges from family planning, as Anna had earlier defined it, antenatal care is for the women, obstetric care, postnatal care, post-abortion care, and proper management of STIs. But in between that, there are also other focus areas that we look at, especially prevention and response to obstetric fistula, very important, and then to a certain extent, management of infertility. But that's mainly on the side of services. Part of my work also includes focusing on aspects of social behavior change communication through a number of programs, and the flagship programs that we have are the ones that are focusing on fostering positive masculinity, and then the comprehensive sexuality education that Roberts and Anna had earlier mentioned. Now, to go to your second question about adolescent and youth-friendly services. I think the bottom line is that adolescents, as Anna had defined them earlier, also have a right to acquire services like any other person. But why are we talking about them in a special way? It's because they are going through that transition that had earlier been defined, and that transition means that they have some unique characteristics that, and part of it is the social changes that they're going through. They require that whatever we serve them, whether it's within the household or whether it's within social services, it's served in a special way, because by their behavior, they come out as special individuals within society. It's just an age group between 10 to 19 years, but it's very unique regardless of which society you go to. So in principle, they can access any family planning services and any sexual and reproductive health services. But one thing that I would want to underline here is that these services, if they are going to be done in the right way, they have to be underpinned by policies. So because societies are vast, societies have different beliefs, we have to have a central way of coordinating the way we approach young people and adolescents, and therefore we have to have central policies. The other thing that needs to happen for within the context of adolescent and youth-friendly services is that they have to be comprehensive. Comprehensive in the sense that we are not only dealing with sexual and reproductive health issues. Adolescents have a big concern around their careers. So most of them usually are within their school-going age, and they have a lot of concern about what they will become in terms of career. They have other concerns regarding drug and substance abuse and trauma as a result of the risks they take and the accidents that they get along the way. Another characteristic that we need to think about in terms of adolescent and youth-friendly services is the issue of timing. Remember, we provide these services, but adolescents at the same time, from one angle, we are encouraging them to go to schools. So they may not be able to access services within the conventional time. So the best way to make these services friendly is to think about providing them over the weekends and evenings, depending on how the contextual realities can allow. The fourth characteristic that we need to consider is the provider. Now, a context like ours, we don't have so many health workers. We have our ratio of health workers to the population is still poor. But again, we need to think about it. How do we make those health workers that we have, how do we train them to be able to respond to the special needs of these adolescents? Adolescents can throw tantrums, and this is a reality across the globe. But somebody serving them must have that at the back of their mind, that I'm dealing with a group that is emotionally charged, and therefore respond to them in such a way. And one other thing that we usually do to make these services friendly is to include the adolescents themselves by having the peer-to-peer arrangements, either sessions or clubs, so that sometimes they get the information much better from those who are thinking in the same bandwidth as themselves. The fifth characteristic to think about in terms of making services use and adolescent friendly is the issue of location. And location could include location within the facility, but also location within the community. So within the facility, where are we placing our services? So in some cases, they have been provided as a corner somewhere so that they have a secluded place that is attractive, that is private, that is confidential for them to freely interact with the service providers there. And then the last thing that is very key in terms of having youth-friendly services is the issue of having meaningful involvement of these young people in terms of the design of these policies. So for me, if somebody wants to have some semblance of success in terms of organizing adolescent and youth-friendly services, those characteristics have to be put in place, and they have to deliberately work through them. And I want to say this, it's quite difficult, especially when you are resource constrained. A country like South Sudan, it's quite difficult, but somebody has to take a deliberate attempt to make sure that these services are available in a way that they respond to the special needs, and I use that in quotes, the special needs of these young people, because you will never find adolescents behaving the same way as any other subgroup in the population. Thank you.
Thank you, Julius. What I wanted to also ask you is, from your experience, what are some of the barriers that you have seen that adolescents face in access and utilization of family planning in general, and when it comes to South Sudan, in terms of the socio-economic and cultural aspects? What are some of the barriers that you have come across? I know by explaining how to make adolescent services friendly, it's also a way of overcoming some of these barriers. But what are some of the ones that you've come across in your experience?
I think the number one barrier is what lingers around the whole society, is the fact that we have still failed to recognize that these young people are special and they need to be treated as such. By and large, if you look at our culture setup, a lot of focus is given to the more adult part of the subgroup of the population, because many times they have matured enough and they can make decisions. And there's that cultural forgetfulness, and I'm putting it in quotes, of this group and being treated as if it doesn't exist. So that's the number one, and it permeates through even our professional spaces. And that leads to the next barrier, which is the attitudes that we have within the health workforce. So that same attitude is transferred from the community to the health space, to the service delivery spaces, to the extent that if an adolescent came and asked for for contraceptives, the first thing would be a reaction that is judgmental, because they are not expected to ask for them. But if you ask the service provider, probably they also initiated their first sexual debut within adolescents, but they have forgotten that that's what happened during their time. So that's one of the biggest barriers, a combination of culture and how it permeates into the professional behavior of health workers. But again, we can't run away from the elephant in the room. We don't have these service delivery points. We have very few health service delivery points, and that translates into having very few service delivery points that respond to adolescents. And that speaks to what I had mentioned earlier, the lack of resources across the board. So with those two, now comes the one that puts them together, policies that are ambiguous. So, and perhaps maybe later on we will have somebody talk about this, but you realize that much as the international conventions we have, like the Universal Declaration of Human Rights, they mention that everybody has access to all services available in their space. This is replicated within the Constitution, could also be replicated within the health policy. But then when it comes to operationalizing these policies, you realize that then you start finding people creating their own policies, asking for parental consent for adolescents to receive services, basically undoing all the commitments that were made by those in the policy making space. But that's partly because there are no clear policies that bring these issues out and say, we're not going to be quiet, we're not going to be ambivalent around this issue of, can adolescents receive family planning services? If you searched all the policies we have, they will say everybody can receive family planning services. But you will not find a paragraph that says there is no restriction to any adolescent getting family planning services. So the absence of that is usually interpreted by those that execute these policies as, let's go back to our traditional way of thinking. Where is your mother? Where is your father? And for me, those are three very big issues we have, of course, besides the other things that also affect other health services that we have across the board. These three are specific to adolescents.
Thank you for that, Busiri. That's very comprehensive. I think you mentioned a little bit about something that Dr. Idiro is going to touch on, the barriers associated with healthcare workers. So Dr. Idiro, tell us a little bit about the work you do, how it relates to sexual and reproductive health, and then tell us about some of the barriers that are specific to health professionals when it comes to provision of sexual and reproductive health services and family planning for adolescents. And what needs to change? How can we take the lead as health professionals in providing information and access to these services for adolescents?
Hello, everyone. From wherever you are watching us from, I'm Dr. Joro Juko. I'm an obstetrician gynecologist. So I think my work is basically on sexual and reproductive health. But what is not specific is I'm not specifically working on adolescent. And maybe this is a part whereby I'm not so much interacting with adolescents. But of late, I get more of adolescents coming to the clinic. And I think some who get early pregnancy, I also happen to interact with them. Okay. I think the definition was well put by Anne. We are looking at this delicate age of 10 to 19 years, which are defined as adolescents. So being a medical doctor sitting in that office, and we call them children, a child comes. Now, how do you start talking to that person about family planning, about sex, when your background at the back, you don't have that defense in the policy that puts it clear that you have, this is how we deal with adolescents. So that part which is missing actually is what is making us having that barrier of not talking to adolescents about their sexuality. And I think Mr. Busiri had put it very clearly. We are still, most of us are still thinking traditionally that this you are still, before you get married, you are not supposed to ask for family planning. You are not supposed to be sexually active. Forgetting that this is someone who is already 17, 15, 17, 19. You are expecting that same person to be going to school. And forgetting that your grandmother actually started getting her children at the age of 15 years. So you are expecting this 17 years to still be sexually inactive, and you expect the same person to go to school. Like me, I started having my kids at the age of 30. So it is a choice. So these adolescents need to be empowered with information. That one I can say it for free. That comprehensive sexual education need to be enhanced. If not in school, and we have forums like this one, this is where we can begin. You guys, the South Sudanese Women Intellectual Group, we can organize youth conferences. I think most of the youth conferences which are happening in South Sudan are most of the time political. we can organize a scientific youth conference whereby we can educate these young people about their sexuality. So, because now sitting in my clinic and I find this young girl and I start telling her, you need to get family planning. You know what next will happen? The relatives will come to me. You are teaching our daughters bad manners. And they don't know. I think I read a post on Facebook. Someone said, as a young man wrote, the only thing that we were not taught by our parents was sex. But we are experts in sex. You see, you are not teaching them, but they are teaching themselves. So what do we need to do? We need to tell them what is good and what is bad. And again, not everyone during adolescence is sexually active. We have to put this one in mind. So you teach them so that they know what is best for themselves. The ones who choose to have sex during adolescence, these are the ones who will definitely know where to go for family planning and know where to protect themselves. So I think this comprehensive sex education, we need to actually target it from the policy level. This thing need to come out. It's not necessarily that I have to go to the hospital and then say, there are some people who say they are conservative, team conservative. Yes, team conservative also we know how to target the team conservative. Anne has said she deals with them at the community level. So what is the community supposed to say to the adolescents? I think our community actually needs to be empowered, also to put the adolescents in the specific community group and talk to them about sexuality, because as of now, these adolescents are still, all of them going to school. You don't expect me, I will not want my kids to start having kids at the age of 15. Maybe if they don't reach my age of having a child, they are supposed to get to the appropriate age of having children. Now you cannot be 100% that when I talk to them, they will abstain. So I need to talk to them on both. Then the choice at the end is there. So we need to involve these adolescents in decision making, and all of them, I can tell you, you can get 80% of them will never be sexually active, and the 20% we know how to protect them, not only from getting pregnant, but also to protect them from getting STIs. I think this is where we need also to empower our medical practitioners.
Mhm.
Thank you.
Thank you, Dr. Iduro. You're a parent yourself, and I'm interested in knowing when it comes from a parental perspective, how do you start this conversation, on sexual education and sexuality? What are the methods that you will use or that you have used? What do you think is appropriate at that age?
I think as a parent, it's also a bit difficult. It's not like me being a doctor. So sitting in my office, when I get an adolescent who comes with the mother, like I got many, 14 years, 17 years, who are already expectant, I will ask the mother to go out. I talk to them as a mother. Then did you think you have done this one well? Did you know about family planning? Are you supposed to finish school? Now this is now in my clinic. But at home, it's a bit difficult. But sometimes we just need that courage. And we always discuss with other mothers. Like a colleague told me, I take my daughters one by one on a day out. So you go with one out, you discuss, they feel there is confidentiality here. So you are alone with them, then you talk to them, you ask them, do you have a boyfriend? Those kind of things. Then they will open up. But what makes us, all of us nowadays, we are all very busy running after money and forgetting to educate our kids. I think me sometimes I just take this time and sit with them and watch the cartoons. People think cartoons are safe. Cartoons are never safe. So they are so much into the cartoons, But when you sit with them, you will find something that touches on sexuality. And that is the point whereby you can actually pick from there, and you ask them, have you understood what that means? They will tell you, yes, it means 1, 2, 3. So what do you think about yourself? Will you do it? Now, why are you not? They will always tell you they will not do it. Then you ask, why are you not going to do it? Then they will tell you 1, 2, 3. Then that is when you come in. But if you are always far from them, you will never get a chance of talking to them. So like there was a day I have these kids in my house from the neighbors. They were all the same age of my kids, around 10 to 14 years. So I prepared for them some snacks. Then when they were very happy eating, then I asked them, hey, you guys, do you have boyfriends or girlfriends? Now all of them said no. So I asked why. Some of the girls said, me, I will wait until I finish my Form 4, blah, blah, blah. Then I asked the boys, they said the same. Then I asked them, why? Why are you waiting? Don't you have anyone now at this time? They said, no, because we need to make our own choices. We need good decision. We don't want someone to drag us the way they want. So that was the time whereby I got a chance of actually educating even the neighbors' kids and told them, yes, this is good if you can wait. It is a good choice because once you are 18, you are able to make your own decision. And I think this is where we need to come in and talk to adolescents. At the community level, I think you can just make gatherings and talk to them. So this is what happens. And in case and also there is a family planning, but it is also good for you to wait. And you will see, we will have difference. Instead of getting kids having kids, I was in Juba recently, and I've seen a lot where I stayed, and it is not a good thing seeing a girl out of school. Because now once the girl have a child, she's a child carrying a child. Now the boy goes back to school. She's a disadvantage at this point because now she has a baby to feed. So even the neighbors will take advantage of her unknowingly that I will support you. And then supporting her, she goes again and gets pregnant again. So the cycle continues. So I think even at the community level, as Anna, what the work Anna is doing, I think it's a good job. But we need to educate the community on how to talk to these children. Thank you.
Thank you, Dr. Idero. I especially like the fact that you indicated that you take the opportunity when it comes up in TV, in discussions, and you use that opportunity to actually educate them and get their views on what they think about sexuality, and what their opinions are. And I'm really glad that most of them are saying, I'm going to wait. That's amazing. So we'll go to you, Anna. I know this topic is like one of the first steps of raising awareness about access to family planning and sexual reproductive health that we've had on this platform. So why do you think it is important for awareness to be raised about access to family planning and sexual and reproductive health services for adolescents? How can this be done? And the second question is a perception that family planning may encourage sexual debut in adolescents, and what is your opinion on the same? That's always the fear, that if you give them access to family planning, then it's like you're opening the door and telling them, go ahead and do what and just explore your sexuality. What do you think about that, and why is it important to raise awareness on this topic?
All right. I must appreciate the previous speakers, Dr. Isdoru, Bushiri Julius has brought out so much to do with these adolescents and family planning. But I think I do not want audience to be very confused of where we are coming from and where we are headed towards. But I think it's very important to understand what family planning is. Because you would say, why would I start teaching my child about spacing? Or when we hear about family planning, obviously it's about IUD, it's about implant, it's about pills. Yeah, those are some of the methods within family planning. But family planning, even condoms, I want people to know that that is also family planning. And I like something that Jurugo mentioned earlier, that we give age appropriate information. We don't expect us to start talking about condoms to a 10 years old. So there is, even within adolescents, we categorize them based on age, which information is appropriate for each age. Because we can't pump them with a lot and they cannot be able to digest at the same time. So basically, why do we need to raise awareness to this importance of raising awareness? I'm going to look at, just looking at our community, what is happening around our community. We have a lot of adolescents getting out of school because of pregnancies. They get, even when we are in denial that our adolescents are not having sex, they are in reality having sex. Their schools are being cut short. We have kids, we have children who are already having children. So creating awareness is very, very important because it comes with information empowerment. These adolescents get to be empowered. They get to know about what sexual reproductive health is all about. What are their rights as individuals? What are some of the services that they're supposed to get and at what age? So that aspect of information to empower them to make the right choices and the right decision is what stands for me here as the importance of creating awareness. And then now also we look at the trends that is happening in our community. Raising this awareness will enable us to reduce on cases of unwanted pregnancies in these adolescents. And if we reduce on the cases of unwanted pregnancies, we're able to keep these adolescents in school, they're able to get education, they're able to be empowered individuals in the future, and they're able to give back to their countries. To the country, South Sudan particularly. So these are some of the benefits that comes with this awareness. And besides that, also, when we raise this awareness, we are protecting them from sexually transmitted diseases. When an adolescent know that there is condom that is available, I'm the age of 15, 16, I've already started having hormonal influxes in me, triggering me to have feelings towards somebody, and perhaps they get involved unknowingly into that. They're able to use these condoms appropriately. They're able to be protected against sexually transmitted diseases, which is the cause of a lot of things right now, including infertility and ectopic pregnancies. So you see, that is the importance of creating awareness. Even there is complications that arises from these sexually transmitted long-term complications can even affect their reproductive health. So this is why we need to importance of raising this awareness. Also, another thing is advancing gender equality. When these adolescents have the information at hand, they're able to have control over their own bodies. They're able to have decisions of, I think I have this information, and I think, just like what Istoro said, his children, they are not ready to have it. They are not ready to have boyfriends or girlfriends because they know that there is consequences that comes with having boyfriends and girlfriends. It will make them lose their education. It will set them behind way steps from others. They see a lot of empowered people. They want to imitate. They want to become empowered like them. So that is why it is important for us to raise awareness about family planning, for them to be informed, for them to make informed choices, and for them to have control over their body. And then another question Can you remind me of the second question?
The other thing that people have a concern about is that if you introduce adolescents or if you expose them to information on family planning, that this may encourage them to start having sex or basically just go out of their way to commit sexual acts and all that. So is this something that should be a concern, or how can that be mitigated? What's your opinion on that kind of thinking?
It's okay. This is quite complex, but I still want to stand and say that to me, exposing adolescents to information pertaining family planning and the services available, to me personally, I will not take it as something that will push them into the act, because when we are providing this information, we are also providing the positive part of what it will do, but we are also giving them the importance. It's like basically it's like a collected effort put together to see the positive side and to know the consequences that comes with reckless acts incorporated in that. So when we talk about family planning, we are not encouraging that because there's family planning, adolescents should go and have sex, unprotected sex, they should go and misbehave. No. We are saying you should have this information, because even when you go and conduct yourself out there as an adolescent, there's consequences, there's repercussions that comes with it. You're likely to lose your education, you're likely not to achieve your dreams of having a job, you're likely not to be stable in the future, you're likely going to go through rough time of maybe contracting pregnancy at the end of it, and that will basically comes with its package on you as an adolescent. So to me, I feel it's about empowering them. And when we are talking about empowerment, it's not leading towards a negative, but I'm looking at it from the positive concept. And that is where also parents' involvement is very important, because we come from different backgrounds. We have religious influences around us, we have cultural influences around us. And now when we put about this information, there are so many factors that will streamline an adolescent towards doing things from all this perspective and knowing what is right and what is wrong. So how do we, there's something about mitigating.
So basically, I think you've answered that question, because you're saying you're giving them a comprehensive information, in the sense that you're telling them the options, you're telling them the disadvantages of actually getting involved in sexual activities early, and you empowering them to be able to make the right choices, as you said before, at the right time. And this is basically empowerment, in the sense that they have all the information and they've seen the pros and cons, and then they're able to make the right decision. I think you've generally answered that question. Now, you've talked about abortion and education coming to a stop because of this. What are some of the other risks that are faced by adolescents because of lack of access to family planning, and how can solutions be found for this?
Okay, so we have already hinted on some of them. We have unintended pregnancies, pregnancy that you're not ready for it, but you end up getting yourself into it. You end up getting sexually transmitted diseases that will have possibly short-term and long-term effect on your reproductive health. And then also you end up sometimes when you have unintended pregnancy, you'll think that I need to complete my education and this is going to stop me. Second thought comes in, I need to terminate these pregnancies. And also they end up going for unsafe abortions, which will also have long and short-term effect on their body. And then also there is someone previously spoke about mental health problems. You know, you get to live with the stigma and the guilt that you have terminated pregnancy. You get to live with stigma that you have gotten yourself STI, maybe HIV, maybe a disease that you cannot even sit in public, you're smelling all over. So it has the depressive and the stigmatization side of it. And also it will lead you into early motherhood and limit your educational exposure, basically. So ways of how we can mitigate this. South Sudan is already doing some of it, as mentioned earlier by Julius and Robert. We have providing comprehensive sexuality educations. We have a number of schools we're dealing with. We're not only targeting adolescents that are in school, even those ones that are out of schools. So even go to marketplaces to create awareness, to talk to these adolescents, basically, about relationships. We are not, when we talk about sexuality education, it's not only about family planning. It's a lot bit about just basically social life we're looking at. So these are some of the things that are happening within Juba and within other parts of South Sudan. And also another thing we're doing is creating awareness through media. Basically, we have a we have radio stations that we conduct shows pertaining that. And then we also do health camping for institutions. We go to Juba University. We have open discussion, even distribution of condoms to these students. Sometimes they even come looking for the condoms up to where we work. So that's when you know that they really know that some of these services are there and they really want it, but they have to do it in hidden because they have to be asking their parents for permissions to do those. And also another thing that Julius put also was those adolescents friendly spaces, and not only those spaces, but ensuring that we have trained healthcare personnel to handle these adolescents. So this is some ways that I feel will work out. And then another thing we're doing at the community level as well, and we feel could also mitigate that, is there is something called Rabita that is very common in South Sudan. So we target some of these Rabita groups. It's a group of women that comes together once in a while. So we ensure that also we reach out to these women. We start holding that conversation of how to start those conversations with their adolescents. They have to know that there's these services for their adolescents. They have to know also the consequences of their adolescents not knowing that these services exist. And we're really doing quite well in that. And it's a gradual process, but we're hopeful that change will definitely happen. Back to you, Anna.
Thank you, Anna. That's very interesting, targeting the rabbiters and using that as a forum to teach women about access to family planning and having discussions about sexuality with the adolescents. Very, very new concept to me, but I think it makes a lot of sense to do that. Thank you for that. Now, you've talked about comprehensive sexual education in schools and even for adolescents who are not in schools. I'd like to ask Dr. Roberts, what are some of the other policies, programs, or strategies that have been set up by partners in the Ministry of Health to improve access to family planning services for adolescents in South Sudan? And what challenges are being faced in implementing these programs? What can be done differently and what has been achieved? What does the future look like for this implementation of these strategies for access to family planning services for adolescents?
Thank
quite a
you,
loaded
Dr.
question there.
Indeed,
Yeah.
it is quite loaded indeed. And let me start by this. I do believe that the Minister of Health has recognized the challenges that we have already been discussing. So as a result of that, there has been an ongoing partnership with UNFPA and so many other international organizations and agencies, sort of a concerted effort to roll out diverse strategies and programs aimed at, ameliorating access to family planning services for our adolescent populace. Notably, what I can mention as a first is that the implementation of the youth-friendly clinics. These are not just regular clinics, these are structured to ensure that our youth receive services in a non-judgmental atmosphere where confidentiality is actually the first thing in consideration. Another strategy that we have been deploying as a country, and of course with support from other partners, is the incorporation of comprehensive sexuality education in school curricula. This has already been mentioned by Anne earlier. This has been included in education curricula. This is not just biology. It's about the rights. It's about respect. It's about responsibilities. It's about relationships. It's about equipping young generation with knowledge and skill to navigate their sexual lives responsibly and safely. Also, another thing that I could think of is, of course, the engagement of the communities and religious figureheads in advocacy programs. The involvement of these individuals is so crucial and has been crucial as they influence perspectives of societies. As a result, this can significantly reduce the entrenched stigmas related to sexual reproductive health that we had already mentioned as one that, when you are giving family planning or when you're educating children on sexual reproductive health, they will, indulge into sexual reproductive health. But of course, they will indulge in earlier sex. But the truth is, sex is already taking place. The most important thing is to give education. And this education has to both these children and also to the communities, to the mothers, to the parents, so that they understand, to the churches, to the religious entities, so that they understand and they can be a force to help us, move on our agenda of ensuring that children at least stay in school so that they can have better futures, their better future. Another thing that I can think of as a strategy is basically our front healthcare workers. We shouldn't overlook them. Specialized training sessions have been organized to ensure they are not just clinically proficient, but also adept at handling the unique sensitivities associated with adolescents' sexual reproductive health. Their role, especially in this country and areas that they are this sexual reproductive health has permeated in, has been actually responsible in breaking barriers and building trust in communities, and a lot of other strategies that have been passed on: the adolescent sexual reproductive health strategy, the family planning strategy, policy that emphasizes, access for youth. So these are a lot of strategies that the country is actually looking at. And of course, it's ongoing, though they are baby steps. At the end of the day, we hope they permeate to all parts of the country. And of course, there are challenges, as part of the last question that you mentioned. The challenges are varied, especially in an area as pivotal as improving sexual reproductive health and family planning programs for adolescents in South Sudan. The country has grappled with resistance from, of course, the particular cultural and religious quarters that I had mentioned earlier. Again, limited resources, both in terms of finances and skilled manpower. These have slowed our progress as a country and the vast challenging terrains in this country, have occasionally made outreach difficult, as well those in the swamp areas, those in the top hills of Eastern Equatoria, all these, the vast country. So these structural barriers have really limited. But it hasn't been all gloom. These baby steps are ongoing, and we have to celebrate our milestones. There has been a heartening increase in the level of awareness among our youth, also the establishment, and more in particular, the operationalization of the youth-friendly clinic in various states, and stand as a testament to the efforts put forward as a country through the Ministry of Health and all other agencies, both international and local, that support this call to ensure that we provide comprehensive sexuality education vis-a-vis family planning services and all others in the country. So as we move forward, my opinion will be that we do not need to rest in our achievements that we have already gotten. They are baby steps, though they are gaining momentum. So we need continuous feedback mechanism should be vital, especially so that we ensure that our programs remain as relevant as possible, as culturally sensitive and effective. So that means we need to continue engaging all these stakeholders, both at the communities and at the top level. The emphasis, I believe, should also pivot towards the capacity building within the local communities. And this is essential, in my view, for the long-term sustainability of these initiatives. Envisioning a future, I see South Sudan, of course, catching up with where adolescents, irrespective of where they come from, has hindered access to SRH and family planning resources. Looking at the future where making informed reproductive health choices is not an exception, but of course a norm in a country such as South Sudan. Thank you so much.
Thank you so much, Dr. Roberts, for that comprehensive overview of what is being done and what the future looks like and the challenges that we're facing. I believe that as we continue, of course, improving access to services in our country, these are challenges that we will eventually overcome, and we will be able to help our adolescents to actually access this information and these services as we continue involving both the community and the Ministry of Health and other partners in ensuring that this eventually is something that is sorted for the adolescents in our country. Now, the next question goes to Busiri. I wanted to know, in your experience, Dr. Roberts has talked a little bit about it, but from your experience, what are the challenges in general and specific to South Sudan of providing modern family planning information services to adolescents? And then after that, you can tell us a little bit about what is considered the best practices for providing modern family planning information to them, and what are the ethical considerations that should be put in mind when thinking about providing modern family planning information to adolescents. So the challenges in your experience, what are considered best practices, and what are the ethical considerations that one should have?
Thank you so much. I think I'll not dwell so much on the challenges, because across the board you could hear all the panelists talking about them. And maybe the only thing I would want to do is to try to give it a bit of structure and say there are challenges at the individual level, the individual who is the adolescent. Then there will be challenges that are around their family, primarily the parents and whoever is caretaking. Then there are challenges that are systemic within our health system, and then challenges that are social. And of course, if you reflect back on what everyone else has mentioned, the systemic issues have been mentioned, the social issues have been mentioned, and the issue to do with parents have a little bit tackled here and there. But I'll dwell on the adolescents mainly, and then tackle a little bit about the parents. So for the adolescents, I think one of the challenges is that an adolescent right now is in an era that is somewhat confusing, because when we were much younger, we knew where to find information, and probably that information was usually information that is vetted, that has been sieved through by professionals, because it was publications that are paper based. So possibly in the newspaper or in a book, a book that has an author, or in a bulletin, a magazine or so. But right now we have internet, and everything is there. And within internet, we have this big elephant in the room, the social media. So that's where we have a big challenge. It's uncensored, by and large. A few things are censored, graphic images that have issues of maybe killing and other things, but there are some topics that are yet to be censored. And so there's a lot of information that is out there that is wrong, but very appealing to these young people. So for me, that's a very big challenge. And then with that information, then when you come to the parents who are still believing that our young people are innocent, by the time you bring your science, by the time you bring your facts, the wrong things have already taken that space in the mind of the young people. And so for me, at that nuclear stage, this now feeds into the systemic issues and the social issues, and makes even service provision very difficult. So for me, I thought I could put a little bit of perspective to that, and our viewers and listeners can think of it in those categories. Now, going to best practices, there is no one shoe fits all with regard to working with adolescents, either within the country or between countries. But I think there are a few things that are agreeable in practice as foundations upon which you could have very, very good programs and policies that provide comprehensive sexual reproductive health services to adolescents, but in particular, contraceptives. So one of the things, and I'll not elaborate on this so much because some of them are self-explanatory. One of the things is government leadership. So government leadership is key, both in terms of providing that stewardship, but also providing that policy framework, as I had mentioned earlier. Without that, every player will be using their own template to do whatever they're doing. And many times it's misleading and it's confusing to an already confused group of young people who are dealing with issues of identity, issues with who they are and what they want to be. So we wouldn't want to add policy confusion to them and whatever has everything to do with them. The second thing that is very important with as a best practice in adolescent programming is having a multi-sectoral approach. So basically, I had mentioned this earlier. Sometimes we think the biggest concern to adolescents is sexual health, but yet their problem is career. They're having challenges with their grades, they're having challenges with their teachers, and that's their primary problem. But for us, we think that STI is their problem, and they don't see it as a problem. So having a multi-sectoral approach, having the Ministry of Health, the Ministry of Education, the Ministry of Gender, private sector, religious institutions, the media, sports institutions coming together and responding to this big issue, galvanized around the same kind of subpopulation that we're dealing with, adolescents and young people. That's very key. The other thing that we need to think about as a key element of best practice is having comprehensiveness and inclusiveness. So I'll mention this: adolescents are never a single group. So here we're telling ourselves it's 10 to 19 years, yes, but 10 to 19 years in Jongole, South Sudan, is different from 10 to 19 years in Yambio, South Sudan. So it's not a homogeneous group. They are having different lived experiences. So having this at the back of our minds and having a comprehensive approach to them and an inclusive approach makes the programs very, 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 very good. The other thing that we cannot run away from is evidence-based. So if you're going to plan and do very good programs for adolescents, they have to be informed by evidence. Now, that's where we usually fall short of glory. But if you have good evidence, then you can respond to the needs. And sometimes the evidence is as simple as having client satisfaction survey at the end of a session at the youth corner, so that they know, so that they tell you what they think about the facilitator you brought today. So sometimes it's as simple as that. The other thing that is best practice, and this has been proved across the board, is all adolescent programs, especially the ones on social behavior change, should be life skills based. So I had earlier on when Dr. Idioro was mentioning about talking to her children. Many times as parents or as service providers, when we're talking to adolescents, we're talking to them in an ad hoc way, in a reactive way. But the best practice is to think of comprehensive sexuality education as constructing a house. So if you're going to construct a house, you're going to start with the foundation, but the material used at the foundation is different from the material used at the roofing. And Dr. Jurugo had mentioned it earlier, that it has to be age appropriate. So what you put at the foundation will determine what you put in the wall, will determine what you put in the ceiling and what you put in the roofing. But what we do, either as practitioners many times or as parents, we are focusing on the roofing. We're telling them, don't have this relationship. But how do you not have a relationship? First of all, you need to be taught how to say no and stick to your no. You need to be taught those cognitive skills to decide and decipher and know that this particular individual approaching me is actually a dangerous person by virtue of having characteristics A, B, C, D. And those things you can't teach them to adolescents when they are within the adolescent period. Sometimes they come before, sometimes at the age of 6. So that's very important that we think of it from a life skills perspective. And of course, looking at the different challenges we have, somebody had already mentioned earlier that our grandmothers, by 15 years, they were in marriage. But right now, and there is a phrase, I don't know who coined it, a phrase called waithood. So many years ago, by 15 years, you would not be bothered about an adolescent because either way she's either in a matrimonial union or she's just about to enter there, and it was okay. But right now we have adolescents who have to live until 25. Just imagine from the age of 15 to 25, another period of 10 years extended, upon which we are telling them, behave like, abstain like your grandmothers did. And grandmothers abstain for only 2 years. Onset of puberty, maybe 13, by 15, they're in marriage. So we need to have the human rights-based approach right now because individuals have different needs because realities have changed. So the human rights-based approach is one of the key elements of best practice. And then, as I mentioned earlier, adolescent-centric. All programs have to be adolescent-centric. We should not focus on the provider. The focus should be on the adolescent, their needs, and how they want to be served. So that's very key. Second last is having professional providers who, in terms of professional capacity, they know what they are doing technically, but they also have the conceptual skills of working with adolescents with all that baggage that comes with them. And then lastly, adolescent programs as a best practice should have a mix of both integrated but also standalone interventions. So it can be integrated within the normal health system, but can also have standalone either within the health facility or also at the community, but above all, to have strong linkages in those. Now, finally, to respond to your issue of ethical many times when you look at ethics as an understanding of what is right and wrong, many times we impose our ethical considerations to these adolescents, and we're thinking they should behave the way we behave. Now, I have no problem with that. Like we said, everything has to be culturally sensitive. But so 3 things have to be put into consideration. 1, the issue of parental consent. At what point do you draw the line? Because sometimes an adolescent comes to you and they are seeking an emergency contraceptive. Anyone in medical practice, anyone in public health knows that by the time someone is seeking emergency contraceptive, they had unprotected sex. And what they want to avert is an unwanted pregnancy. So you're giving this adolescent an option between having an unwanted pregnancy or sending them away because they want an emergency contraceptive because you believe they should not have had sex, but they've already had it. So that's an ethical dilemma that most of us have to consider, because if you pass that stage and then they conceive, then we have opened them to two things. We have opened them to having a child that they never wanted, and with all the lived consequences that Anne had mentioned earlier, but also a number we never even track. So we don't know how many adolescents we're losing as a result of that. Second thing that is tied to ethical considerations is issues of legal requirements. So for most countries, the age of consent is 18, and that includes consent to sexual relationship. But then you know that the puberty has no respect for age of consent. So these adolescents are having sex anyway. And that's why even Dr. Idoro had mentioned that she's beginning to see teenagers coming to the facility. So by the time teenagers are coming to the facility, yes, we have these legal requirements to know that this is a child, but they are already having children. So with regard to the legal requirements, now how do you deal with the father of that child when they come to your antenatal clinic with their 15-year-old wife? So as a practitioner, you know that this is a criminal case because this was rape, because someone below 18 years cannot consent to sexual relationships. So those are things to think about. And then finally, as health workers and by and large, the ones who are within the subcategory of medical practitioners, at the end of all your training, you make a medical oath to preserve and promote health, to preserve life and promote health. Now, many times, these lives we're talking about, at that point when we're making an oath, maybe we never think that some of these lives are going to be lives of adolescents. And now these adolescents will appear to your clinic with life-threatening issues, and then you throw the oath away. So those are three things that I thought we need to think about consciously as ethical issues, but mainly tied between the law, the society, and our practice. Thank you.
I think the ethical issues is a discussion that is quite huge, and many people will end up on either sides of the divide, and it's something that can cause a bit of friction when it comes to adolescents, because now you're thinking these are people who are under their guardians, under their parents, and even when they reach 18, they're still under their parents and their guardians, and they don't have even the economic ability to sort out their health issues, that they don't bring themselves to hospital on their own, they're taken. And now you have to deal with the parents, you have to deal with the guardians, and you also have to deal with the adolescent. And it's a very difficult group to manage, even within pediatrics, because you have to think about their confidentiality. You have to think of them as human beings, like the way you're saying human rights approach. And then you also have to think, okay, these ones are under a parental oversight. How do you deal with this? So it's a discussion that needs to be had, and hopefully there can be a way through a middle ground to be able to help them and still remain within ethical practice. So Dr. Idoro, the next questions are for you. When it comes to family planning options, now that you've seen quite a number of adolescents in your clinic, what are some of the options that are recommended for this demographic? What are the pros and cons of those options? Which ones do you personally recommend? And how do you go about advising them on family planning methods? What are the things you consider?
Okay. I think now when we, like just Anna said earlier, when we speak of family planning, people think like we are advocating for the adolescents to get family planning. Family planning usually, I think when we define family planning or contraception, is actually the intentional prevention of pregnancy by artificial or natural means. So I think when advising people on family planning, what I always say is one family planning method that is 100%, you will never get pregnant, is abstinence. So you start actually with that one. if you abstain no matter what, unless you become the second Virgin Mary. So even for the adults who come to the clinic and they are seeking the most effective family planning, I tell them the most effective one, which is 100%, is abstinence. All the others we are giving, there is failure rate. And you start listing for them. This is the failure rate. So if this failure rate is 0.01%, why are you expecting the 0.01% to happen to someone else and not you? So I think actually when advising someone on family planning, tell them actually, yes, there is no family planning which is 100%, but abstinence is 100%. So it is a choice of the adolescent to choose. Because eligibility to family planning, they're eligible to all the types of family planning that are available for the adults. So there is no specific family planning that is designed for adolescents. So I think the best is to take them through all the family planning, explain to them the failure rate, and actually the risk associated with all the different types of family planning. And one of the risks includes pregnancy that they are actually avoiding. So pregnancy can be a risk. So what some parents do, they think actually prevention of pregnancy is more important than prevention of STIs, which is actually on the contrary. I think people should advise adolescents in terms of the risk of family planning that they use. And in the event that they contract STIs, what are the consequences, which can actually lead to infertility in the future. Now they are making a decision at the age whereby they don't know what the future holds. And now they reach the age where they actually want children, they are not able to get because they have contracted STIs and they get blocked tubes, and this is much, much later. So I think we have to weigh on all the different types of family planning. And like I said earlier, we need this community involvement much more than anyone else to talk to our adolescents. If I talk to my kids and they all tell me, no, we are not going to have friends until 18 years, you take it with a pinch of salt. Maybe they're actually scared of you. So you talk to someone else, talk to them, maybe you will get a different answer. So I will not rely only on the answers given to me by my children that this is what they are going to do. So let them also listen from someone else, like we have said, the community. So they will listen and then they will put all things together. And again, I think we need to have it has been echoed, adolescent-friendly spaces. Like here in Kenya, in KNH, Kenyatta National Hospital, we have that high-risk clinic. And that high-risk clinic, majority of the people who come to that high-risk clinic are actually the adolescents. So that they feel they are safe. It is a safe space for them. So they actually come there and they know there is confidentiality in those spaces, whether they want to take family planning or whatever they need VCT services. So I think my message will still go back to Anne. As much as you are dealing with the rabita, which are mostly women who are adults, I think you also need to talk to them because some of them are actually nurses or community health workers who work in the health centers, so that they actually have a different view on these adolescents once they enter the clinic. I know Juba is very small, and you might enter a clinic and then someone, musita bineta filan. That one now actually makes that girl to shy away from whatever she has come, and she will just say she comes for something else. I think this attitude is more common. What are you doing here? What do you want with family planning? I think there is no question like that. Whoever comes for services, you sit them down, talk to them, and act professionally, not like the mother at home or the neighbor at home. So I think they need to feel safe, and they feel the adolescents, they need to feel that whatever they do it will not reach their parents. Like we have also said, the age of consent. Again, like we said, if a 15 years old come and we said, no, this must be rape because she has not actually consented for sex. What if the boyfriend is also 15 years old or 16 years old? So I think we also need to consider also the boy child at the same time. So it is not always the boy who is on the wrong and the girl on the right, but we actually need to talk to them all together. And we tell the boys to respect also the girls like their sisters, because they are still not yet of age of like having a family. So that everyone continues with their education. Yeah, thank you. And not unless I miss something else.
No, that's okay. Thank you, Dr. Idioro. I think you've actually emphasized on making sure that the service is adolescent friendly and there's confidentiality that's maintained, even if you know the adolescent. In the case of your story for Juba. Then the other thing I wanted to ask you is something that Anna has talked about, some of the risks that adolescents then face when they have no access to this information or are unable to utilize these family planning services. In your experience and in your practice, what is the percentage of unwanted pregnancy associated with lack of access to family planning services for adolescents? How can this be mitigated? And we know that unwanted pregnancies may lead to illegal or backdoor abortions that may lead to complications and even death. What can be done to prevent this, and how does access to family planning services prevent this from happening?
Okay. And I think I might not get a data from where I practice, because where I practice is purely private, a private hospital, and we might not be getting the same number that the public facilities is also getting at the time. But I think I've just picked some data from WHO, which are actually the estimate, like as of in 2016, I think there was an estimate of around 21 million girls aged 15 to 19 years, and mostly in developing regions, as included, who became pregnant, and 12 million of those ones actually gave birth. So I think this alone is a high number, and considering that one, and I don't know the number specifically in Juba, how many adolescents are getting pregnant every year, but I think I have something from Kenya, where a study was done in a certain district, which actually showed that almost 22% of girls 15 to 19 years have an unmet need for contraceptive. So I think this one also lead to, and the same study showed that around 13,000 girls drop out of school annually in Kenya because of unintended pregnancy. So I think this one we can also consider as part of our data, because we are neighbors, and some of the cultures are actually the same. So this is a high number that I can actually say it, and I can actually relate it to South Sudan. I don't know, maybe Anna can give us if they have those data of unintended pregnancy in adolescents. But I think considering that one from WHO and the ones from Kenya, it is actually a high number. So, and the risks which are included with this unwanted pregnancy, like we said, no, the risk which is involved with unmet needs for family planning, pregnancy is actually one of them. And now getting pregnant at an early stage is also associated with gender-based violence from the partner and the parents, because now you feel that bitterness. You are not expecting your daughter to get pregnant at this age. Now she's already having a child. So actually, the girl faces a lot of backlash from both the parents and the partner themselves. So now again, this one may lead again, like I said earlier, it can lead again to the girl getting pregnant again for a second time and a third time. So I think it actually, puts the girl in a position of not achieving anything in life. This one I can say. And then at the same time, no education. She will end up just being a mother of children. She will not be able to achieve her educational career. And there will be no employment. And this actually will lead to poverty. Now, a girl like this will have no say. Like, I think that nowadays women are more empowered, and they said, my money is my money, and the one for the husband is our money. So now this girl will not have her money. So where is the money going to come from? So she will be totally dependent on the husband, and a husband who is going to be very aggressive, because now you are actually bringing kids every year. You don't know what to do. So I think they become a liability, and they get exposed to so many infections like STIs at the end of the day. So I think these are the consequences of early unintended pregnancy. And in the event that they wanted to terminate pregnancy, when you want to terminate pregnancy, you need to know the facility. So the expensive facilities are the better facilities. You will not be able to afford an obstetrician or a gynecologist who will be willing to do for you the termination of pregnancy because you don't have money. So you go to the cheapest places who will offer you the same services, which will at the end of the day actually will not be the same services, because the effect will be much. And I think that is where we are coming from as South Sudan, and we are saying many girls present to the hospital with this criminal abortion, and we have and we think they are the ones who add up to our maternal mortality, which I don't think so, because we need to have the data to support that actually illegal abortion contributes to high maternal mortality. Yes, they can contribute, but as we discuss here, what can we do better to prevent that? So I think these are all the risks that will come in handy with a lack of access to family planning. Thank you, Anne.
Thank you, Dr. Idoro. It's quite sobering, to think about illegal abortions and the effect on the adolescent population, especially the girls, because of all the complications that can occur due to that. And I think that is one of the most important factors that make this access discussion that we're having very important, because here we're trying to prevent death, we're trying to prevent disease, we're trying to prevent infertility, we're trying to prevent loss of continuation of education. We're trying to prevent children being brought into a world where the mother is actually unable to take care of them, whether it's nutritionally, economically, physically. So there are quite a number of effects down the road that can be prevented by actually giving adolescents the information, and access, so that they're able to make the right decisions at the right time, as Anna had said. Now, we would ask about some statistics, and I think Julius, you have some statistics from South Sudan. Maybe you can just give us a few pointers on that, and then we can go to Anna in a bit.
Yeah, I just wanted to highlight that out of every 1,000 childbirth 158 children born by adolescents. So at least that's a statistic we have officially within the national documents. And but of course that could also be a conservative figure because what we know at least is that child marriage is rife, and wherever there's child marriage is one of the biggest risks to teenage pregnancy. The other thing that we see, at least from the receiving end, is every time we're having fistula repair campaigns, almost a third of the number of the women that are coming for repairs are actually teenagers, some as young as 14 years. So that tells you that the problem, and that's just the tip of the iceberg, because not all of them will get fistula. So the ones who get fistula are just that small percentage that had obstructed labor. But there are those who manage to give birth and remain at community. But that tells you that even without official statistics, the situation is that bad.
Yeah, quite unsettling, to think of it in that manner, the tip of the iceberg, meaning there's so much that we can't see because many of these adolescents don't actually show up at the health facility. And yes, child marriage is very rife within the communities of South Sudan. And this is a problem that we'll be dealing with for years to come. And it will take a lot of advocating and campaigning to just get people to consider not doing this anymore and not exposing these adolescents to the risks that are associated with early childbirth and lack of access to sexual and reproductive health facilities. And of course, there's an imbalance of in terms of being able to make decisions for themselves when they're put in these situations, and that then leads to further problems in this particular demographic. Now, we're almost at the end of our discussion, and I just want to thank you all for the insights that you've given. Anna, I'd like you to talk about, from a public health perspective, what do you think is the best approach towards advocating for family planning information for adolescents, and has enough been done to educate the public on this? What can we do differently? And especially within the South Sudan context, before now we do our final remarks and recommendations.
Okay, I think I feel what I wanted to talk here was spoken by Julius in his best practices as some of the best approaches that we could take from public health perspective to ensure that we advocate for family planning. He spoke about a multi-sectoral approach, whereby we need to bring on board religious leaders. We need to work closely with religious leaders to ensure that we promote the agenda of this access to information and utilization of family planning services. Because when we look at some of the barriers, we're looking at cultural and religious. So we need to work hand in hand with these cultural leaders, with the religious leaders, to ensure they need to understand the importance of doing this, where this will lead the country if it is not addressed, and where the country stands at is a risk factor towards the future. And then also another thing that we spoke about is another thing that I feel is very important is the public-private partnership. It's a very important approach that could aid advocating for family planning, because public, let me say, private sector brings so much strength to the table, and they are the people who are so close to the community. If we just recently we had a national validation workshop for family planning policy for South Sudan, and the director for reproductive health at the Ministry of Health was talking about how at the clinics the private sector are calling for more commodities. Commodities are being utilized, but they are doing it behind the doors because they are not allowed to access it publicly because they will face stigma due to judgment, due to a lot of finger points. So I think really we need to strengthen this public-private partnership to ensure that there is this advocacy for family planning is, and then also engaging the youth-led organizations. Also, it's a very important approach because I feel the best solution to adolescents is using adolescents themselves. So this is also another approach that I felt we could take it up at the public health perspective to ensure that we advocate for family planning, utilization, and service provision. That is all from my side, Anna, unless I left something out.
No, thank you. Thank you so much, Anna. That's a very comprehensive answer. And I'd like to thank you for that overview. Now, we've come to the end of our discussion. It's been a very enlightening discussion. And I'd like each one of you to just finalize with your final remarks and recommendations. So we'll start with Dr. Roberts. You can give your final remarks and recommendations, and then Busiri, you'll give your remarks, and Dr. Idioro, then finally Anna. Thank you. Dr. Roberts.
Thank you, Dr. Anne, for the opportunity. I know we have talked a lot. Of course, from the conversation, there seem to be success mixed up with a lot of challenges. But of course, despite the little success as a country that we have made, we have to remain on. I think for a brighter future, we must continue to invest in our young people to ensure that they have the knowledge and means to lead a reproductive life. I'll end with 3 recommendations that I think, if implemented, could improvement. And one, first and foremost, of course, Anne had already strengthening partnership that has to be between the community. That we need that partner.
Sorry, Dr. Roberts, you're hanging a little bit, I think. If you can just repeat that statement. Yes, go ahead.
Yes, the first recommendation I would be thinking of, let me move closer, could be partnership between the government, NGOs, UN agencies, and the community, so that we tailor our services to the needs of the community. Also, most importantly, we need to provide continuous training to our already existing healthcare providers, and of course to the new one, and not only the healthcare providers, to the teachers, because they are front of comprehensive sexuality education, especially in secondary.
Okay, I think Dr. Roberts is encountering a few issues with his internet there. He's talked about partnerships being important, whether it's private and public partnerships. He's talked about involving the community, and he's also talked about training, which of course would involve teachers in terms of comprehensive sexual information education, would involve health professionals, and I think would also involve parents eventually. So when he comes back, we can have him give some the other final recommendations that he had. So Busiri, if you can give some final remarks and recommendations.
Yeah, thank you so much for having us here for the past 1 hour and a half or so. And I'm very grateful to have shared this platform with these very brilliant people with the very interesting reflections. But I'll say this in my final remarks. By nature, man is a sexual being. And if you love statistics, you realize that if someone lives to their full lifespan, let's say they live up to the age of 80, they may have spent 90% of that time being sexually active. So this topic is not a topic to shy away from, regardless of what you think. And so, regardless of how conservative a society is, when puberty sets in, adolescents will definitely initiate sexual relationships. And when they do that, at least we have right now a tool in our hands, comprehensive sexuality education, that we can comfortably utilize to help them maneuver through the complexities of adolescence, the uncertainties and the risks that come with it, so that they can have at least a clear chance at having a healthy adulthood, which we always look forward to, because by and large, we are longer on earth as adults than as adolescents or as children. And therefore, I want to say this, recognizing that adolescents are not a homogeneous group. They have different characteristics. They are affected by different things as far as their context is concerned. A deliberate investment in adolescent sexual and reproductive health is definitely an investment in society. So I want to leave this recommendation, just one recommendation. With this, we have to talk more within and between ourselves, and we have to do this without fear or favor. Thank you.
Thank you so much, Busiri, for that. And yes, I think the emphasis is adolescents are not a homogeneous population, and we have to look at them as individuals and decide what each individual adolescent actually needs in terms of sexual and reproductive health education or access to those services. Dr. Roberts, you had gone off a little bit there. If you can just finish with your recommendations.
Yeah, thank you. I think my network was disturbing. So I talked about strengthening partnership between the government, NGO, and also our communities. We also need to continue building the capacity of the existing health workers and the new ones who are coming, and also including teachers, because at the end of the day, they are more of responsible in ensuring the operationalization of comprehensive sexuality education. And as we move on in this AI modern world, we need to use media and technology tools for education and awareness. And I think this is actually a recommendation that might be appealing to young people as they move, they enjoy technology and all that. And I think that's actually the three recommendations that I had started before the network went off. So we need to be unified to ensure that every individual in South Sudan can make informed choices and about their sexual reproductive health. Thank you, Anne.
Thank you so much, Dr. Roberts. I think the one thing that I find interesting in this recommendation is the use of the media to reach out to these adolescents, because this is something that they are using every single day. They have on their hands, they're surrounded by it, and that would be a very effective way of actually reaching a large number of their population with this information. Thank you so much for that. Dr. Idioro, what are your final remarks and recommendations?
Okay, thank you once again, Anne. I think my final remarks is we should, at the policy level, we need to have this comprehensive sex education active. It has to be, there should be utilization of the family planning services and youth-friendly clinics. And we need this community involvement in teaching our youth on responsible, societal, and culturally oriented sex education. So my final remarks actually will go out to the women, aunties, grandmothers, grandfathers, uncles, and everyone in the community to be talking to their boys and girls about sex education and risk of early pregnancy. I think this is my one and only recommendation. We need to talk and talk and talk. And at the end of the day, I know the youth are going to make their choices. And again, like Jurugu has said, we need to have our tailor-made services that is fit to our society. Because even if you go through all the WHO guidelines, at the end there is a disclaimer that these are the guidelines that they have set in place, but it is not imposed to any country. So you adopt it, tailor make it to fit your society and your culture. I think both Julius, Robert, and Anna, you are working on this. I think this is now your work to move forward. Thank you.
Thank you so much, Dr. Iduro. Very interesting, the disclaimer that WHO puts, but I think it makes a lot of sense because we are all culturally different. And just the same way Busiri says that adolescents are not homogeneous, nations, cultures, communities are not. And I like the way you're emphasizing on community participation, it becoming a community effort to actually educate these adolescents so that they have the information and are able to make the right choices at the right time. Thank you so much for emphasizing on community involvement. Anna, final remarks and recommendations.
Okay, my final remark would be we need to know that these adolescents are having sex and they will continue to have sex. And it's all up to us to find ways of how to save the future. I would also say my recommendation is adolescent agenda and issues should really be a national matter. We need the will of the politicians, we need the will of the government to take this up seriously. Because if it is taken up seriously from higher level, everything will work out. And when I talk about it should be a national agenda, I heard recently that our health budget has been increased to 15%, and 5% of it is going for family planning. So if also we can give a portion for adolescent sexual reproductive health in general as a package, that will really do great, and a lot of things will shape up to the community level. So that's basically what I want to put forward, Anna. Thank you.
Thank you so much. So basically talking about our leaders committing to actually making a difference when it comes to adolescent access to sexual and reproductive health services. So I think generally what we have said is that we need to stop burying our heads in the sand, and we need to offer adolescents a space where they can easily access and utilize these services, and we need to empower them with information so that they are able to make the right choices at the right time, and therefore prevent some of these risks and consequences of adolescents who have not been able to access family planning that leads to multiple things, including acquiring sexually transmitted diseases and early pregnancies and all the risks associated with it. So I want to thank each and every one of you, Busiri, Anna, Dr. Idioro, Dr. Roberts, for joining us on the platform and for availing yourself for this discussion. We have learned a lot. You have given a lot of information that we need to think about. And I hope that the people who are involved with policy making, who are involved with strategizing when it comes to access of adolescents to these services are here and listening and taking down the points. And we hope that with this information, then even those who are listening to us are able to empower the adolescents around them, and they're able to treat them in a way that they don't feel stigmatized and are able to open up and share what they're experiencing and what their needs are. So thank you so much for for being advocates for the adolescents and for being advocates for their access to sexual reproductive health services, which is something that many people try to look away from, but is quite important in our society today because things have changed. Um, uh, Girls are not getting, or young people are not getting married at the same age they were, and they have many, many years where they're very, they are very sexually active, and therefore they need this information to be able to prevent some of the consequences of them not accessing these services. So thank you so much, and I am so grateful to have had you on the panel and for sharing your expertise and your experience, and we hope to have you on the South Sudanese Women Intellectuals Forum again. And thank you to our audience for joining us. And I want to thank Aisha and the technical team at the background, and for those who have supported the forum since its inception and continue to support it. So thank you everyone for joining, and goodbye, and have a lovely evening or morning or afternoon from wherever you are. Thank you so much, and bye.